Hello, my name is Mihail Petrov. I'm a neurosurgeon from Department of Neurosurgery, Pirogov Hospital. We saw some wonderful cases in the live and recorded session so far. So now I guess it's time for really bad cases, cases that make you wonder, why did I become a doctor? So this is the topic about complications. If anything can go wrong, it will definitely go wrong. Unfortunately, this is the case in endovascular neurosurgery. This is a very nice publication about complications and a series of 275 patients. In this publication, the complications were divided in 4 main groups: mechanical complications, technical complications, judgment errors, and critical events. You can see the percentage of all those complications in this series. Unfortunately, 30% of these complications lead to new neurological deficit. So this is why it's very important to know them and to learn how to avoid them. And if they happen, and they will happen, to know how to manage them. From the last 3 groups, we're going to show you an example about these complications. Examples from our center. The first case is about technical complications and unintended embolization. This is a case of a 31-year-old right-handed male patient with intracerebral hemorrhage from left frontal perisagittal AVM. It was graded Specially Martin 2. During the embolization, we couldn't see the onyx, and when we zoomed out, we actually saw this thing over here. Dreadful picture. This was onyx extravasating from the microcatheter inside the Petrov segment of the internal carotid artery. We did DSA. You can see the result: complete occlusion of the left ICA of this young man. What to do? We started panicking. You can see our solution. We made 4 passes with 4x14 balloon catheter and tried to smash the onyx against the walls of the vessel and to try to recanalize the vessel. You can see that there is MTK2B recanalization of the internal carotid artery. There was a little less flow in the ACA over here. The good thing in this patient was the good flow contralateral from the contralateral right ACA. These are the control images. 1 year later, the patient survived, hopefully. You can see some pieces of onyx inside the bifurcation of the left MCA. This is the control MRI 1 year later. After intensive rehabilitation, the patient was able to walk, even to ride his motorbike. This is the MRA actually. The next complication, thromboembolic complications. This is a 62-year-old female patient with subarachnoid hemorrhage. She arrived at day 3 at our hospital. She was Hunt and Hess 1, Fisher 2. On the CTA, we saw this posterior communicating artery aneurysm, and we went for endovascular treatment. While navigating with the microcatheter, we made a control DSA, and you can see this over here, complete occlusion of the MCA. We had to take some important decisions to abandon the procedure, try to recanalize the vessel, or to continue with the procedure, do what we came for. Actually, this is what we did. You can see on this picture over here, we called the aneurysm. After that, we went for thrombus extraction of the thrombus. We made 4 or 5 passes with the solitaire stent retriever with actually no result. And after that, we went for a salvage interarterial thrombolysis, again with not satisfactory result. You can see almost no recanalization. Even though we left the patient on double antiplatelet therapy, hopefully, you can see on this DSA, she has a very good collaterals from the anterior cerebral artery to almost the whole territory of the MCA. On 1 year later, this is the control CT, almost no ischemic zones on the scan. And this is the CTA. You can see that the patient actually recanalized the MCA on the double antiplatelet therapy. And maybe the interarterial thrombolysis, we are not sure, because of the bad picture at the end of the procedure. This is our last case. This is the worst type of errors, judgment errors, where we're not sure that we took the right decisions, where we should have done what we have done. This is a 49-year-old female patient with sudden onset headache and loss of consciousness at her workplace. At the emergency department, a CT scan and CT angio were conducted, and right temporal lobe ICH was diagnosed, and ophthalmic segment aneurysm. You can see over here, this is the ophthalmic artery, this is the aneurysm. The dimensions were 7.7 millimeters neck, dome, and the neck was 4 millimeters. We tried to oversize the aneurysm and try simple coiling. You can see the result over here. We didn't like it. There was a small prolapse of loops of the coil inside the ICA, so we removed this coil and tried to do it with a balloon assisted. You can see even worse result. Some loops of the coils prolapsed in the ICA. We continued. Things got worse with every single step. You can see while traversing with the second microcatheter in the hope to place a stent in order to push the loops of the coils to the walls and maintain patency of the ICA. Even more coils prolapsed, and the picture is really bad. Fortunately, we placed a solitaire stent. You can see a good flow in the MCA, ACA. The patient was discharged with no neurological deficits on double antiplatelet therapy. Unfortunately, 2 months later, the patient was admitted again at the emergency department with status epilepticus, and an MRI was conducted, and a glioblastoma was diagnosed in the zone of the hemorrhage. She was operated, the diagnosis was confirmed, and the patient was sent for radiation chemotherapy. So, the take-home messages: choose your patients carefully, plan your procedures meticulously, pay attention to the details. Mistakes will occur, learn how to manage those complications. Thank you.
Questions from the audience? Can I ask you, in the case with the AVM, did you manage to understand there is some rupture of the catheter,
Yeah,
the proximal catheter, or more proximal to the catheter itself, maybe at the body of the catheter? Was some
Yeah,
problem?
there was a rupture in the microcatheter.
But at the proximal market, is it Apollo catheter? Apollo.
Yeah.
So is there the proximal marker some problem, or
No,
below it? Inside the guiding catheter?
The largest almost you see the P2 segment. If any other segment, you will think, okay, maybe do something else. P2 segment practically is very difficult to maintain.
Did you try to extract it, the onyx, or just balloon? Because the Russian group showed when they lose onyx or something like that, they will go with mechanical thrombectomy, remove it.
You will try with stent viewer when you have a small part of onyx. There are big cast of onyx.
If it's at the early time, the first 60 to 90 minutes, it can penetrate and to remove it. Like they said, I don't have experience. Me too. Yeah, the results are nice. He's lucky. So it happens.
Yeah.
It happens. It's very important to know how to manage this complication. It's not every time this lucky scenario is going for a good end.
For sure.
So thank you. Other
Thank you.
questions? Okay, so.